Okay, imagine holding a grapefruit, right? And it's about the size of your heart. And then picture all these like tiny roadways inside carrying blood.
Yeah.
That's kind of what we're diving into today, the world of coronary anatomy, and physiology. Oh, and huge thanks to the London Heartbeats Z Academy for their support on this one. They have like over 150 courses on all things heart, from EKGs to like crazy imaging stuff. Check out their website, follow them on Facebook, Insta, and YouTube, free updates, and you won't want to miss their future discussions, seriously.
Duh.
But yeah, back to that grapefruit, or, well, your heart, I guess.
It is pretty amazing, like, how such a small organ can be so powerful and so complex at the same time.
Right. It's incredible. So, like, starting simple, the coronary arteries, those are the roadways, right? Branching off the aorta, bringing all that oxygen-rich blood to the heart muscle itself.
Exactly, yeah. The aorta, like the heart's main highway, I guess you could say, it gives rise to the coronary arteries right at its base, like a major interchange, making sure the heart, which is like the engine for everything, gets its fuel, you know?
Okay, so we've got the aorta, that's the main supplier, and then branching off are the coronaries. I think the source material mentioned 3 main ones, is that right?
Yeah, 3 main players. You've got the right coronary artery, the RCA, the left main coronary artery, or LMCA, and then the left anterior descending, the LAD, which branches off the LMCA. Oh, and speaking of the LMCA, it also gives rise to another one. Can't forget the left circumflex artery, the LCX. So it's like the LMCA is a big fork in the road, splitting into 2 super important pathways.
Okay, so RCA, LMCA splitting into the LAD and LCX, got it. But then there's this whole coronary dominance thing. What's that about?
Ah, good question. Shows how everyone's heart is like a little bit unique, you know? So coronary dominance, it means which artery, either the RCA or the LCX, takes the lead in supplying blood to certain parts of the heart. Imagine different traffic patterns depending on how the city's laid out. In most people, it's the RCA that's dominant. So it supplies like the posterior part of the heart, including a really important part called the AV node. But sometimes the LCX takes over, supplying those areas instead. And then, sometimes, not as often, you get co-dominance where both arteries kind of share the job equally.
So some cities have one main highway, others have 2 major routes splitting the work. Interesting. But why does it even matter? Is it just like an anatomical quirk, or does this dominance actually affect anything?
Oh, it definitely matters, especially when we're talking about like blockages or problems in specific parts of the heart. Knowing which artery is dominant, it helps doctors predict how a blockage might affect blood flow and therefore how well the heart's working. Like knowing which roads are most important for, emergency services to reach different parts of a city.
Makes total sense. Let's dig into each artery a bit more. The source material gets pretty specific, even down to measurements and segments. Honestly, kind of overwhelming with all the anatomical details, so maybe you can help break it down.
Of course, yeah. Let's start with the RCA. So it comes from the right aortic sinus, kind of at a right angle. Like picture a road branching off perpendicularly from the main highway. And then it travels along this groove, the right atrioventricular groove, nestled between the right atrium and right ventricle.
The source material also mentioned it being like embedded in fat. Is there a reason for that?
Yeah, that fat layer is like a cushion. It helps protect and insulate the RCA as it goes around the heart. Now, the RCA, it's divided into 3 segments, proximal, mid, and distal. So the proximal part goes from its starting point, the ostium, to about halfway towards the acute margin of the heart. That's like a sharp bend in the road. Then the mid segment keeps going to that acute margin, and the distal one goes from there to where it gives off the PDA, the posterior descending artery.
So it's not just one long tube, more like sections with like specific landmarks.
Yeah.
I guess that makes sense with the heart's shape and all, reaching different spots.
Right, exactly. And the diameter of the RCA, like you said, it changes along its length, and it also depends on that coronary dominance we talked about. For example, in right dominant hearts, the proximal RCA is usually wider, around 3.9 millimeters. But in left dominant hearts, it's narrower, something like 2.8 millimeters. Think of it like different lane widths on a highway depending on how much traffic there is.
Wow, that's tiny for something supplying such an important organ.
It is, but don't underestimate it. The RCA also branches out, giving rise to other important arteries, each with its own job, You've got the conus artery that supplies the right ventricle's outflow, track the exit ramp for blood leaving. Then there's the SA nodal artery going to the heart's natural pacemaker, the SA node, and the acute marginal artery running along the edge of the right ventricle. And like we said, if the heart's right dominant, the RCA also gives off the PDA, supplying the back of the heart and usually a posterolateral branch too.
It's like a whole branching tree, making sure every part of the heart gets what it needs. But things don't always go perfectly right. I mean, the source material mentions variations, anomalies. Like, Detours in the roadmap.
Yeah, you're right. Sometimes there are variations in how these arteries form, and those variations, they can be important. We call them coronary anomalies.
So, like, the city planners accidentally put a roundabout in the wrong place,
Yeah.
or a road goes through a tunnel instead of over a bridge.
Yeah, exactly. And depending on the anomaly, it could be totally harmless or it could lead to some serious issues, even life-threatening ones. Take L-CAPA, for example. That stands for anomalous left coronary artery from the pulmonary artery.
Uh-oh, that sounds kind of serious. What happens in El Capa?
Well, normally the left coronary artery comes off the aorta, carrying oxygen-rich blood. But in L Kappa, it mistakenly connects to the pulmonary artery, which carries deoxygenated blood. Imagine delivery trucks accidentally going to the wrong depot and bringing back the wrong fuel. So the heart muscle doesn't get the oxygen it needs, and that can lead to some really big complications, especially for infants.
That does sound pretty bad. Is it common?
Thankfully, no, it's pretty rare. Al Kappa, it only affects like 1 in 300,000 live births. But it's so important to catch it early and treat it so it doesn't cause lasting damage to the heart.
That makes sense. There's also something called myocardial bridges, I think. Can you explain those?
Myocardial bridges are interesting. Imagine a road that, instead of going over a bridge, it actually dips down and tunnels through the heart muscle itself. That's basically what happens in a myocardial bridge. Part of a coronary artery burrows through the heart muscle instead of running along its surface.
So what happens when the heart beats, when it contracts? Doesn't that squeeze the artery?
Exactly. During systole, when the heart muscle contracts, yeah, it can compress the artery that's in the myocardial bridge. It can reduce blood flow. Most of the time, not a huge deal. But sometimes it can cause symptoms like chest pain, especially when someone's exercising and the heart's working harder.
Wow, that's crazy. It's amazing how something that seems so small, like a little detour in the artery's path, can have such a big effect.
Yeah, it really shows how precise and balanced the heart's anatomy is. Even small variations can have consequences, which is why understanding these anomalies is so important.
Speaking of seeing the coronary arteries, how do doctors actually visualize these tiny pathways? I know the source material mentioned angiography. Can you tell me more about that?
Angiography is a super powerful tool. It lets doctors see the coronary arteries by using a special dye that shows up on x-rays. It's like highlighting the roads on a city map.
So they create a roadmap of the heart's highway system.
Exactly. And to get a complete picture, they use different angles, different views during the angiography, like taking pictures of a sculpture from different sides to see all the details. They use the anteroposterior, or AP view, where the x-ray goes straight to the chest. And then there are the RAO and LAO views, the right and left anterior oblique views, where the x-ray source is angled to the right or left.
So like trying to get different perspectives, different angles on something complex. I can see how that would be helpful for like pinpointing the exact location of a blockage or something.
Exactly. Each viewer shows different parts of the coronary arteries, so they can really assess the structure and any potential problems.
It's incredible how technology lets us see inside the body so clearly.
Mm.
But how do these intricate coronary arteries even form in the first place? It seems like such a complex process.
It's a pretty amazing journey. It starts all the way back in the early embryo, like watching a city being built from scratch, with all its roads slowly taking shape.
So where do the coronary arteries fit into this whole development story?
Well, in the early embryo, the heart gets its blood supply from structures called aortic arches. They're like temporary highways for the developing organs. As the embryo grows, these arches transform and give rise to the major arteries we see in adults, including the aorta.
So like a major renovation project, transforming temporary roads into permanent ones.
Exactly. And the coronary arteries, they start as separate vessels from the aorta. Then, as they grow, they extend towards the aorta, kind of like side streets connecting to a main highway. This connection is really intricate, involving cell growth and something called programmed cell death, or apoptosis.
Apoptosis. That sounds a little dramatic for development.
It might, but apoptosis is actually a very controlled process. Think of it like demolition crews strategically removing old buildings to make way for new construction. In this case, apoptosis helps create the openings where the coronary arteries join the aorta, creating a smooth connection.
It's amazing how such a delicate process can create something so essential for survival. But I can see how this development, if it's disrupted, could lead to those coronary anomalies we talked about.
Right, exactly. The heart's development is a whole sequence of perfectly timed events, and if something disrupts that, there can be lasting consequences.
Okay, we've talked about how the heart gets oxygen-rich blood through the coronary arteries. But what happens to the blood after it delivers the oxygen? How does it get back to the lungs to be, reoxygenated?
That's where the coronary venous system comes in. It drains the deoxygenated blood from the heart muscle and carries it back to the right atrium, where it can be pumped to the lungs.
So it's like the return route on our city map, carrying the empty delivery trucks back to the depot.
Perfect analogy. And just like with the arteries, the venous system has its own network of vessels. The main player is the coronary sinus. It acts as a central collecting channel, and then there are several cardiac veins that drain into it.
Okay, so tell me more about these cardiac veins. Are there different ones for different parts of the heart?
Absolutely. The heart is super organized, even in its drainage system. You've got the great cardiac vein, which runs alongside the LAD, collecting blood from the front and side of the heart. Then you've got the posterior cardiac vein, which, like the name suggests, drains the back wall of the left ventricle. These two big veins merge to form the coronary sinus.
So they're like two big rivers converging into one larger waterway.
Exactly. Then we have the middle cardiac vein, which drains the back of the interventricular septum, that wall separating the ventricles, and it empties into the coronary sinus. And then there's the small cardiac vein, draining the right ventricle, and the oblique vein of the left atrium, which drains the left atrium.
Yeah, it's a whole network of tributaries feeding into the coronary sinus. But the source material mentions something called the Bayesian veins, too. What's special about them?
The Bayesian veins are really interesting because they bypass the coronary sinus altogether. They drain directly into all four chambers of the heart.
Wait, directly into all four? That's different from the other veins.
Yeah, they're a bit unusual. Think of them like independent drainage pipes scattered throughout the city just in case the main sewer system backs up. There's still a way for wastewater to escape.
Interesting way to put it. So like a backup drainage system, providing an alternative route for blood to return to the heart. Why would the heart even need that?
The exact reason is still being debated, but they probably play a role in regulating blood flow and pressure in the heart, especially in certain areas.
Okay, so we've covered the coronary arteries, the veins, and even the Bayesian veins. It's clear the heart has a pretty elaborate plumbing system. But let's shift gears a bit. Let's move beyond the anatomy and talk about the dynamic world of coronary physiology. What are the key factors that determine how blood flows through this whole network?
It all boils down to supply and demand. The heart needs a constant supply of oxygen, just like a city needs a power grid. And the coronary arteries, they deliver that oxygen-rich blood, like those power lines delivering electricity.
So if the heart needs more oxygen, it needs more blood flow. But how does the coronary system adapt to those changing demands?
That's where things get really interesting. The coronary arteries can actually adjust their blood flow. They dilate to increase flow when demand is high, and they constrict to reduce flow when demand is low. It's like a smart traffic management system that adjusts based on real-time conditions.
I'm starting to realize how dynamic and responsive the whole system is. It's not just static pipes. It's a living system that constantly adapts.
Exactly, and this ability to adapt is key for the heart's health. But it's not a simple on-off switch. There are multiple things that regulate coronary blood flow. The heart's own mechanisms, the nervous system, and even signaling molecules from the cells lining the blood vessels.
Okay, so many moving parts. Let's unpack some of these mechanisms. What about the heart's own control over blood flow? Is it like a city having its own internal traffic management system?
Yeah, we call that coronary autoregulation. It's pretty remarkable. It's the ability of the coronary arteries to keep blood flow relatively constant, even when arterial pressure changes. Like a city adjusting traffic to make sure everyone gets to work, even during rush hour.
So even if blood pressure goes up or down, the heart still gets what it needs.
Within a certain range, yes. Coronary autoregulation works best between 60 and 140 millimeters of mercury. But if the pressure goes way too low or too high, this mechanism can get overwhelmed.
Makes sense. What about the nervous system? Does that play a role in regulating blood flow too?
Absolutely, yeah. The autonomic nervous system controls things like heart rate and breathing. It's like the city's command center, always monitoring and adjusting. So, with the heart, the sympathetic nervous system, the fight or flight response, can increase heart rate and how forcefully the heart contracts. This means the heart needs more oxygen, and the coronary arteries respond by dilating, increasing blood flow. It's like sending more fuel trucks to the city during a power surge.
So stressful situation, heart rate goes up, needs more oxygen, and the arteries widen to deliver it. Pretty cool. What about the parasympathetic nervous system? Any role there?
Yeah, the parasympathetic, the rest and digest system, does the opposite. It slows down heart rate, reduces how strongly the heart contracts, and therefore lowers the need for oxygen. So the coronary arteries constrict a bit, reducing blood flow. like reducing the number of fuel trucks when demand is low, conserving energy.
A constant balancing act between those two systems, fine-tuning everything to match what the heart needs at any given moment.
Exactly. But it's not just the nervous system calling the shots. The cells lining the blood vessels, the endothelial cells, they release signaling molecules that can affect blood flow too.
Signaling molecules, like little chemical messengers in the heart's communication network.
Yeah, great way to put it. Some key players are nitric oxide, NO, which relaxes blood vessels and increases flow. It's a vasodilator. Then there's endothelin, which does the opposite, constricts vessels and reduces flow. And prostacyclin, another vasodilator that's super important when there are blockages, helping to keep blood flowing through alternative routes.
So like different traffic signals in the city, coordinating the flow of cars based on local conditions, like construction or accidents.
Exactly. All these signals, along with the nervous system and the heart's own mechanisms, they make sure blood flow through the coronary arteries matches what the heart needs at any given time.
This is all making a lot more sense now. It's clear the heart's blood supply is super dynamic and responsive. But you mentioned coronary vascular resistance earlier. What does that mean and how does it affect things?
Coronary vascular resistance is basically the friction blood encounters as it flows through the arteries. Imagine pushing thick liquid through a narrow pipe, the resistance you feel. The higher the resistance, the harder it is for blood to flow, and less blood reaches the heart muscle.
So what causes this resistance? Is it just the size of the vessels?
Vessel size plays a part, but it's not the only thing. How thick or thin the blood is, its viscosity, that matters too. And even the pressure from the surrounding tissues can influence blood flow. Imagine a road with potholes, narrow lanes, and heavy traffic, all slowing things down.
So narrow vessels, thick blood, or pressure from surrounding tissues, all that equals higher resistance and less blood flow.
You got it. And what's fascinating is that coronary vascular resistance, it's not a fixed number. It changes depending on different factors. Like when the heart muscle is working harder, it releases metabolites like adenosine, and that can dilate the coronary arteries, reducing resistance and increasing flow. Like the city opening up more lanes on the highway during rush hour to handle the traffic.
Great analogy. But then on the flip side, things like atherosclerosis, where plaque builds up inside the arteries that can narrow the vessels and increase resistance, reducing blood flow even when the heart needs more oxygen.
Exactly. Like a traffic jam from road construction, limiting how many cars can get through even when demand is high. That's why understanding this resistance is so important. It determines how well the heart can get the oxygen it needs. Any problems with this balance can cause trouble.
Okay, so we've talked about the bigger coronary arteries and what affects blood flow through them. What about the tiniest blood vessels, the capillaries? Don't they play a huge role in actually delivering the oxygen to the heart muscle cells themselves?
Oh, absolutely. The coronary microcirculation, which includes those small arteries, arterioles, and capillaries, that's where the real action is. Imagine a network of tiny streets and alleys delivering goods to every shop and home in the city.
So the final step in the delivery process, making sure oxygen and nutrients get where they need to go.
Exactly. And the capillaries, they're perfectly designed for this. They have super thin walls, allowing for easy exchange of oxygen and nutrients between the blood and the heart muscle cells.
It's amazing how, even at that tiny level, everything's made for optimal function. How is blood flow controlled in this microcirculation? Is it just a passive process?
Not at all. The coronary microcirculation is tightly regulated, making sure blood flow matches the heart's needs at the cellular level. Think of it like a sophisticated traffic management system for those tiny streets, optimizing routes and keeping things moving smoothly.
So what are some of the key players in this microscopic control system?
We can group the control mechanisms into three types: physical control, metabolic control, and neural control.
Okay, let's break those down one by one. Starting with physical control, what are we talking about there?
Physical control, it refers to mechanisms that regulate blood flow based on the physical properties of the blood vessels themselves. One important one is myogenic regulation, which is the ability of the smooth muscle cells in the vessel walls to adjust their tone based on pressure changes.
So if pressure goes up, the smooth muscle cells constrict to prevent too much flow. And if pressure goes down, they relax to allow more flow, like pressure-sensitive valves keeping the flow steady even when things are fluctuating.
Exactly. That's a great way to picture it. This myogenic response helps keep blood flow relatively stable. But these vessels don't just respond to pressure, they also respond to shear stress, which is the force exerted on the vessel walls by the blood flowing through them.
Shear stress. So the faster the blood flows, the greater the shear stress on the walls, like a river current against the riverbank.
You got it. And this increased shear stress actually triggers the release of nitric oxide, remember, that potent vasodilator from the endothelial cells.
So the city widens the roads in areas with lots of traffic to accommodate the flow.
Precisely. Increased flow, more shear stress, leads to vasodilation, which then further increases flow. It's a perfect example of how the body keeps everything in balance.
Oh, intricate. The heart has so many backup systems in place. What about metabolic control? How does that work?
Metabolic control means regulating blood flow based on what the heart muscle actually needs. Think of it like the city adjusting its fuel deliveries based on how much energy each neighborhood is using.
So if a part of the heart muscle is working harder, it needs more oxygen and therefore more blood flow.
Exactly. One of the stars of this metabolic control system is adenosine.
Adenosine, isn't that connected to caffeine somehow?
It is. Caffeine blocks adenosine. But for the heart, adenosine is a powerful vasodilator. Heart muscle cells release it when they're not getting enough oxygen.
So when a part of the heart muscle is starved for oxygen, it sends out an SOS in the form of adenosine.
Precisely. And that adenosine, it binds to receptors on the smooth muscle cells around the vessels, which ultimately leads to vasodilation and increased blood flow to the oxygen-deprived area, like the city prioritizing fuel deliveries to neighborhoods experiencing a blackout.
It's like the heart has its own internal communication system, letting the vessels know where the need is greatest. But adenosine isn't the only thing involved in metabolic control, right?
Right. Other factors like changes in pH, which tell us about acidity levels, and even how much oxygen is available, all that influences blood flow in the microcirculation. Basically, when oxygen levels are low or acidity increases, blood vessels dilate to increase flow and deliver more oxygen and, buffer the acidity.
It's amazing how the heart fine-tunes its blood supply so precisely. What about neural control? We talked about the nervous system's role with the bigger coronary arteries, but does it also affect blood flow at this microscopic level?
It does, but it's a bit more subtle in the microcirculation. Both the sympathetic and parasympathetic parts of the autonomic nervous system can have an effect, but it's not as pronounced as in the larger arteries.
So like the city having some control over the traffic in those tiny streets, but not as much as on the main roads.
Yeah, good analogy. The sympathetic nervous system, with its fight-or-flight response, releases norepinephrine, which can cause both vasodilation and vasoconstriction, depending on what receptors are present on the smooth muscle cells.
So it's a bit more complex than a simple on-off switch.
Exactly. Usually, sympathetic stimulation leads to vasodilation overall in the coronary microcirculation, but how much dilation varies.
What about the parasympathetic system? Any action in the tiny vessels?
Yes, it does play a role. The parasympathetic system, the rest and digest one, releases acetylcholine, and that generally causes mild vasodilation in the coronary microcirculation, like the city promoting slower, more relaxed traffic in residential areas.
Okay, that makes sense. But you also mentioned something called paracrine control. What is that and where does it fit in?
Paracrine control is interesting. It's all about the influence of signaling molecules that are released from cells near the blood vessels, particularly during clot formation. Imagine a construction crew rerouting traffic around a road closure.
So it's a localized response to an emergency situation, trying to keep some flow even when there's an obstruction.
You got it. For example, when a clot forms in a coronary artery, platelets come rushing in and release a bunch of different signaling molecules. These molecules can both dilate and constrict nearby blood vessels, adjusting blood flow in that specific area.
So a dynamic response, minimizing damage and keeping things moving as best as possible. Pretty incredible. But we've talked a lot about the left side of the heart. Is there anything different about blood flow in the right coronary artery, the one supplying the right ventricle?
Good question. And yes, there are some interesting differences. The right ventricle, the one pumping blood to the lungs, it has lower pressure and needs less oxygen compared to the left ventricle, which pumps to the rest of the body. Think of it as a smaller, quieter neighborhood compared to the busy downtown.
So the right coronary artery doesn't have to work as hard.
Exactly. Lower pressures, less demand, means the right coronary artery faces less resistance and can work fine even with less flow. And this difference shows up in its structure, too. The right coronary artery is usually larger in diameter and has a thinner, less muscular wall. Think wider, more relaxed roads in a quiet neighborhood.
It's amazing how the heart is so perfectly tuned to the needs of each chamber. Like a city with different zones, each with its own infrastructure built for its specific demands.
Precisely. And this brings us to another important part of coronary physiology. What happens when blood flow gets blocked, when there's stenosis?
Ah, yes, stenosis, blockages. The source material goes into a lot of detail about the effects of stenosis. It's not just the blockage itself, right? It's how it affects blood flow and the heart's ability to function.
You're absolutely right. Stenosis, which is the narrowing of a coronary artery, usually from atherosclerosis, it disrupts normal blood flow and triggers a cascade of changes that can really affect how well the heart works, like a huge traffic jam on a major highway, messing up the whole city.
So we need to look beyond just the blockage itself and think about how it affects the heart's whole traffic flow system.
Exactly. And to understand this, we need to talk about Bernoulli's equation. It might sound complicated, but it's actually pretty simple. Bernoulli's equation, it describes the relationship between pressure, velocity, and the cross-sectional area in a fluid flow.
Okay, I vaguely remember that from physics, but how does it relate to the heart?
Well, it explains how pressure changes as blood flows through a narrowed artery. Basically, as the artery narrows, the blood flow speeds up, but the pressure drops. Like a river flowing through a narrow gorge, the water gets faster, but the pressure decreases.
So blood squeezes through the narrow part, speeds up, but the pressure goes down. Why is that a big deal?
Because that pressure drop, it's not constant, it gets worse as blood flow increases. We call this flow-dependent pressure drop. It's like traffic getting even worse during rush hour, even though the roadblock is the same size.
So the more blood the heart needs, the bigger the pressure drop across the stenosis, limiting blood flow even more. It's like a vicious cycle.
Exactly. And this is why even a small stenosis can have a big impact on the heart, especially during exercise or stress when it needs more blood.
Okay, so the heart's got to challenge a blocked road. What does it do to compensate? Does it just give up, or does it have any tricks?
The heart is incredibly tough. It doesn't give up easily. One of the first things it does is dilate the blood vessels downstream from the stenosis, reducing resistance and trying to maintain blood flow, like the city opening up side streets and detours to go around the blockage.
So the heart's traffic management system kicks in, rerouting blood to keep things moving as best as possible.
Exactly. But as you can imagine, there's a limit to this. As the stenosis gets worse, the blockage gets more severe, and those detours become less effective. It's like more and more cars trying to squeeze through those side streets, eventually leading to gridlock.
So at some point, the heart can't compensate anymore. What happens then? What are the consequences of stenosis?
Well, it depends how bad the stenosis is and how much it's affecting blood flow. Early on, when it's mild, the heart might be okay at rest. But when you exert yourself, when the heart needs more oxygen, blood flow might not be enough, and you could get chest pain, which is called angina. It's like the city having brownouts during peak hours because the power grid is strained.
Okay, so angina, it's a warning sign that the heart is struggling. But what happens when the stenosis gets worse?
As the stenosis progresses, the narrowing gets worse, the heart can't compensate as well. Eventually, even at rest, blood flow might not be enough, and that can lead to more serious problems, even a heart attack.
Like a full-blown blackout, everything shuts down.
Exactly. Where the blockage is and how bad it is plays a big role in how much damage is done. A blockage in a major artery supplying a big part of the heart is way more serious than a blockage in a smaller branch.
The source material talks about critical stenosis. What's that? Is that like a code red for the heart?
It's definitely a serious situation. Critical stenosis means a very severe blockage, usually 90% or more reduction in the artery's diameter. Blood flow is severely restricted even at rest, and the heart muscle is at high risk of ischemia, which means it's not getting enough oxygen and damage. It's like a complete road closure on a main artery, cutting off supplies to a huge part of the city.
So critical stenosis, that's a life-threatening situation that needs...
Yeah, it needs immediate attention to get that blood flow back and prevent permanent damage to the heart muscle. It's like calling in the emergency crews to clear the roadblock ASAP and get traffic moving again.
That makes sense.
Mm.
But how do doctors figure out how severe this stenosis is? Do they just measure how narrow it is on an angiogram, or are there other things they look at?
It's not just about measuring the narrowing. While the percentage of blockage is important, it's not the whole picture. We also have to consider how that stenosis is affecting blood flow, what its functional impact is. It's like knowing a road is 50% blocked isn't enough. We need to know how much it's slowing down traffic. Doctors use different techniques for this, including measuring something called flow reserve.
Flow reserve, I've heard of that, but explain it like I'm five.
Think of flow reserve as the heart's ability to increase blood flow beyond its resting level, like when it needs to work harder. It's like a city's ability to generate more power during peak hours when everyone's using more electricity. A healthy heart with good flow reserve can increase blood flow a lot when it needs to, but stenosis can limit this reserve, making it harder for the heart to keep up.
So it's a measure of how flexible and responsive the heart is, how well it can adapt. Makes sense. But how do they actually measure this flow reserve? Do they have, like, special flow meters for the heart?
There are a couple of ways to do it. One is by measuring what we call absolute flow reserve, which is also known as coronary flow reserve, or CFR. It's basically a ratio that compares the maximum blood flow possible during vasodilation to the resting blood flow.
So it's like measuring the difference between a city's normal power output and its mass capacity during peak demand.
Exactly. A healthy heart can usually double its blood flow when it needs to, getting a CFR of at least 2. But stenosis can lower CFR a lot, limiting the heart's ability to adapt.
Okay, so lower CFR, bad news. You mentioned another kind of flow reserve, relative flow reserve. What's the difference there?
Relative flow reserve, it compares blood flow in an area with stenosis to an area without stenosis, like comparing traffic on a jammed highway to a clear side street. This gives doctors a more specific idea of how much that stenosis is actually slowing down blood flow.
So it helps them figure out if that blockage is a real problem or if the heart is managing okay. Interesting. The source material mentions another technique too, fractional flow reserve, or FFR. Tell me about that one.
FFR is a common technique. It's invasive, but it gives us a really accurate assessment of how important that stenosis is, physiologically speaking. It measures the pressure difference across the stenosis when the vessels are dilated as much as possible.
So measuring the pressure drop across that traffic jam when the city is doing everything it can to keep things moving.
Exactly. And FFR is useful because it directly shows us how that stenosis is affecting blood flow and the heart's ability to get oxygen.
Sounds super helpful. How do they even measure it? Is it complicated?
It's done during a cardiac catheterization. They put a thin, flexible tube, a catheter, into a blood vessel, usually in the groin or arm, and guide it to the coronary artery. Then a special wire with a pressure sensor goes through the catheter and is positioned across the stenosis.
So they're measuring pressure right at the blockage. That's pretty cool.
It is, yeah. And to get the most accurate reading, they give a medication, adenosine, to dilate the vessels as much as possible. This mimics what happens when the heart's working harder, like during exercise, and lets them see exactly how that stenosis affects blood flow.
So they measure pressure before and after the stenosis, and that gives them the FFR number.
Exactly. FFR values, they usually range from 0 to 1. 1 means there's no significant stenosis, and the closer to 0 it is, the worse the blockage is.
So lower FFR, bigger problem for the heart, makes sense. But why is FFR so important? How does it actually help patients?
FFR, it helps doctors decide on the right treatment. Studies show that patients who have stenosis and an FFR below a certain level, usually 0.8, they benefit a lot from things like stenting or bypass surgery. So it helps figure out which blockages are actually causing trouble and need to be fixed, and which ones the heart is handling okay.
So it's not just about finding blockages. It's about figuring out which ones are actually causing problems, like having a sensor that tells you which traffic jams are the worst and need attention. FFR sounds really useful.
It is, yeah. It can help avoid doing unnecessary procedures on patients who have stenosis that isn't causing issues, while also making sure that the people who really need treatment get it.
That's great. Really personalized medicine. But I'm curious, we've been focusing on stenosis in the bigger arteries. What about the microcirculation, those tiny vessels? Can problems happen there, even if the main arteries are clear?
Definitely. Think of it like problems in the city's small streets and alleys, even when the highways are fine. If the microcirculation isn't working right, it can affect blood flow and how the heart works, even without blockages in the big arteries.
So like the delivery trucks can't reach the houses even though the main roads are open?
Right. One common reason for microvascular dysfunction is left ventricular hypertrophy, or LVH.
Okay, LVH. What is that exactly and why does it cause problems?
LVH means the heart muscle, specifically the left ventricle, gets thicker. The left ventricle is the main pumping chamber. This thickening often happens in conditions like high blood pressure, when the heart has to work harder to pump blood. Think of a city needing bigger, stronger pumps to handle higher water pressure.
So the heart muscle gets bigger, stronger, but what's the problem with that?
The problem is, even though the muscle grows, the blood vessels supplying it might not grow at the same rate, like having a more powerful engine but not upgrading the fuel lines. The heart muscle needs more oxygen, but the microcirculation can't deliver enough, and that causes issues.
So the heart works harder, but doesn't get the fuel it needs. That sounds like trouble.
It is. This mismatch can lead to lower flow reserve, making the heart more likely to experience ischemia, even without blockages in the main arteries.
Interesting and kind of surprising.
Yeah.
I wouldn't have thought a stronger heart could be a problem. Anything else that can cause problems in the microcirculation?
Yeah, another big factor is problems with nitric oxide production. Remember, nitric oxide helps dilate blood vessels, and anything that messes with its production or how it works can really affect blood flow, especially in the microcirculation. It's like if a city couldn't widen those smaller streets when traffic gets bad.
So instead of opening up when needed, those tiny vessels stay narrow, making it even harder for blood to get through.
You got it. And a bunch of things can mess with nitric oxide production: high cholesterol, diabetes, high blood pressure, smoking, all that. They basically sabotage the heart's traffic management system, making it harder for blood to flow properly.
It's like one problem leads to another. All this talk about blockages, resistance, and blood flow problems brings up a big question. What happens when the heart muscle doesn't get enough blood flow, when it experiences ischemia?
That's a great question. It gets right to the heart of the matter, literally. Ischemia, it's a serious condition where the heart muscle doesn't get enough oxygen, and it can cause a whole bunch of bad things to happen. Think of it like a city having a power outage.
The lights go out, everything stops working.
Well, not right away. When ischemia happens, the heart muscle cells try to adapt. They switch from aerobic metabolism, which needs oxygen, to anaerobic metabolism, which doesn't. Like those backup generators starting up when the power goes out.
So they're trying to keep things running, but they're using emergency power.
Exactly. But anaerobic metabolism isn't as good, and it produces lactic acid as a byproduct. That can build up and damage the heart muscle cells even more, like those generators polluting the environment. And if ischemia continues, the heart muscle runs out of energy, it can't contract as well, and eventually the cells die. That's called necrosis.
So like the city running out of fuel, essential systems shutting down, sounds bad. Is all ischemia permanent? Can the heart recover if blood flow starts again quickly enough?
That depends on how long the heart goes without oxygen and how severe the ischemia is. There's reversible ischemia and irreversible ischemia.
So there's hope for recovery sometimes. What's the difference between the two types?
Reversible ischemia, it's like a temporary power outage. The heart isn't getting enough blood, but if blood flow returns quickly enough, the cells can recover and go back to normal. Like flipping the switch back on, everything starts working again.
So what causes reversible ischemia? Is it always blockages?
Not always, no. There are a couple of ways it can happen. Sometimes it's supply-induced, meaning something temporarily stops blood flow, even if the arteries themselves are okay.
What could cause that kind of temporary interruption?
One possibility is a coronary artery spasm. The artery suddenly constricts, reducing blood flow, like a sudden traffic jam that clears up quickly. Another possibility is a small blood clot that briefly blocks an artery but then dissolves or breaks apart, restoring blood flow.
So that's supply-induced. What about demand-induced reversible ischemia?
Demand-induced happens when the heart needs more oxygen than it's getting, even if the arteries are clear. Like a city's power grid getting overloaded during a heat wave, everyone's blasting the AC. The supply's there, but the demand is just too high.
So even a healthy heart can have ischemia if it's pushed too hard.
Yes, exactly. And the good news is, with both types of reversible ischemia, if blood flow comes back quickly, the heart muscle cells recover and work normally again.
That's good to hear. But what about irreversible ischemia? What makes it different and what happens?
Irreversible ischemia is more serious. It's like a power outage that lasts so long it causes permanent damage to electrical equipment. The heart muscle is permanently damaged because it hasn't had enough blood flow for too long.
So even if blood flow comes back, the damage is already done.
Unfortunately, yes. Those damaged cells can't recover, they die. And restoring blood flow quickly is critical to prevent this permanent damage. Studies show that irreversible damage usually starts after about 20 minutes of complete ischemia.
It's a race against time to save the heart muscle.
Exactly. Every minute matters. And how much damage happens depends on a few things: how long the ischemia lasts, where the blockage is, and if there are any collateral vessels that can provide alternative routes for blood flow.
Collateral vessels. You mentioned those before. Remind me what they are and how they help.
Collateral vessels, they're like back roads and side streets that can bypass a blocked highway. Alternative paths for blood flow that develop over time when there's chronic ischemia. Think of it like the city making detours to keep traffic flowing when a main road is closed.
So collateral vessels can help limit the damage from ischemia. Good to know. But I have a question. We've been talking about restoring blood flow fast, but can that cause problems too? Can reperfusion itself be harmful? Is it possible to have too much of a good thing?
Interesting question. And the answer is yes, sometimes. Restoring blood flow, reperfusion, it's super important for saving the heart muscle, but the process itself can actually cause more damage. It's called reperfusion injury.
Reperfusion injury. restoring blood flow causes damage. That's kind of weird.
It is a bit of a paradox. It's like when a city gets power back after a blackout, but that sudden surge of electricity causes some circuits to overload and fry.
Okay, I get it. What's actually going on in the heart during reperfusion injury? What's causing the damage?
Several things are happening. One is the formation of free radicals. Remember those metabolic byproducts we talked about earlier? They can build up in the heart muscle cells during ischemia. When blood flow comes back and oxygen rushes in, those byproducts react with the oxygen, and that creates free radicals.
Free radicals, aren't those unstable molecules that damage cells? So it's like that sudden rush of oxygen is actually fueling a fire?
Exactly. Those free radicals can attack the heart muscle cells, making reperfusion injury worse. But it's not just free radicals. Inflammation is involved too. When the heart muscle is damaged, it triggers inflammation. That's the body's natural way of healing. But when reperfusion happens, those inflammatory cells can sometimes go overboard and release substances that damage the heart muscle even more.
So it's like the city's emergency responders accidentally making things worse while they're trying to put out the fire.
Good analogy. And to make things even more complicated, reperfusion can trigger apoptosis, that's programmed cell death, in some heart muscle cells. That means some cells die even after blood flow returns, like a city experiencing aftershocks even after the earthquake.
Wow, reperfusion injury sounds tricky. It's like you need to restore blood flow to save the heart muscle, but that can cause more damage. Is there any way to protect the heart from this?
That's a key question, and researchers are looking into ways to minimize reperfusion injury. One interesting area is preconditioning.
Preconditioning, what's that? How does it work?
Preconditioning is the idea that short periods of ischemia can actually protect the heart from longer periods of ischemia later on. It's like giving the heart a workout, exposing it to a bit of stress, which somehow makes it stronger and more resistant to bigger stress later.
That seems counterintuitive. How can not giving the heart enough blood be a good thing?
It does sound strange, but studies have shown it's true. Think of it like giving the city's power grid some controlled brownouts to prepare it for a potential blackout.
So small doses of stress make the heart stronger against a bigger attack. What kinds of preconditioning are there?
There's acute preconditioning and delayed preconditioning. Acute preconditioning, that's when the protection happens, right after those short ischemic episodes. So if the heart goes through some quick interruptions in blood flow, it becomes more resistant to damage from a longer ischemic event later on, like a rapid response system that kicks in after a minor problem.
So the heart learns and adapts quickly.
Right. Now, delayed preconditioning, it takes a bit longer. The protection usually shows up about a day after the initial ischemic episodes and can last for several days.
So it's a slower adaptation, building up resilience over time?
Exactly. We don't know everything about how preconditioning works, but it probably involves a lot of complex cellular signaling, like the city upgrading its infrastructure and communication systems to be ready for emergencies.
So preconditioning is like giving the heart a heads up, letting it prepare. Incredible. Is this something that can be done on purpose, or does it just happen naturally?
Good question. Researchers are trying to figure out how to induce preconditioning artificially, using medications or other techniques.
So like a vaccine for the heart, protecting it from ischemia.
Yeah, exactly. Early studies show some promise, but we need more research to make it work in real patients.
It's exciting to think about being able to use preconditioning to protect the heart. The source material also mentioned post-conditioning. What can you tell me about that?
Post-conditioning is another strategy. It's about protecting the heart when blood flow returns to an area that's been ischemic, like trying to limit the damage from that electrical surge when the power comes back on.
So minimizing damage during reperfusion.
Exactly. The idea is to cause short, intermittent periods of ischemia during those first few minutes of reperfusion, like turning the power on and off a few times to regulate the flow and prevent circuits from overloading.
That sounds tricky. But how does this intermittent reperfusion actually protect the heart?
We don't know everything yet, but it seems to mainly target the mitochondria, those energy powerhouses in the cells. By causing those short ischemic episodes during reperfusion, we're somehow helping the mitochondria work better and reducing those harmful free radicals. It's like giving the generators a little break to cool down before they have to work hard again.
So instead of just suddenly giving the heart a ton of oxygen, you're giving it a chance to adjust. Makes sense. But what happens to the heart muscle after ischemia? Does it always go back to normal, or are there lasting effects even after blood flow returns?
That's a good question. It depends how bad the ischemia was and how long it lasted. Sometimes, even after blood flow returns, the heart muscle doesn't start working normally right away. This can lead to what we call stunned myocardium, and hibernating myocardium.
Okay, those sound interesting and maybe a little scary. Let's start with stunned myocardium. What does that mean? Is the heart muscle literally stunned?
It's a good way to describe it. Stunned myocardium means the heart muscle isn't contracting as strongly as it should, even though it's getting enough blood again after ischemia. It's like the muscle is in shock after the ischemia and it needs time to recover.
So blood flows back, but the heart muscle is still having trouble.
Exactly. It's like the city slowly getting back to normal after a big disruption. It takes time.
Does stunned myocardium go away eventually, or is it permanent?
It's reversible, that's the good news. The heart muscle gets its function back, but it can take a while, sometimes hours, sometimes days, depending on how bad the ischemia was.
So the heart muscle needs time to heal and get strong again. What causes stunned myocardium? Only big heart attacks.
Not always, no. Stunning can happen even without a heart attack. It's often seen after procedures like angioplasty or bypass surgery, where the heart muscle might experience some brief ischemia during the procedure.
That makes sense. So a temporary setback, the heart will bounce back. What about hibernating myocardium? How is that different?
Hibernating myocardium is a longer-term condition. It happens when blood flow is reduced for a long time. We often see it in patients with severe coronary artery disease. The heart muscle basically goes into hibernation, it slows down its metabolism and how strongly it contracts so it can survive with less oxygen.
So it's like the city going into energy-saving mode during a power shortage, just trying to survive.
Exactly. It's a survival tactic, letting the heart get through a long period of low oxygen.
But is this hibernation forever, or can the heart muscle wake up and go back to normal?
That's what's so interesting about hibernating myocardium. It can be reversible. If we restore blood flow to that hibernating muscle, like with angioplasty or bypass surgery, the heart function can improve significantly.
That's incredible. It's like the city coming back to life after being in the dark for ages. How does the heart muscle even know when it's okay to come out of hibernation? What starts that recovery process?
That's a tough one. We're still trying to figure out exactly how it works. It seems like the heart muscle cells are always checking their surroundings, responding to changes in oxygen levels and other metabolic signals, like the city having sensors that tell it when the power grid is stable and it's safe to go back to normal.
So the heart is constantly adapting, making the best of tough situations. Remarkable organ.
It really is. And the fact that the heart muscle can adapt to not having enough blood for a long time and potentially recover, it just shows how resilient it is.
This has been an amazing journey into the heart's inner workings. We've talked about the whole network of blood vessels, the balance of supply and demand, the problems with stenosis, and how adaptable and tough the heart is.
We've covered a lot, and it's clear how well designed the heart is.
But like with any complex system, things can go wrong. We've seen that with blockages, stenosis, ischemia, even the challenges of restoring blood flow.
And we've also seen how well the heart can adapt, compensate, and protect itself.
It's been fascinating, and I think I understand my own heart a lot better now.
Yeah.
Before we finish, can you remind us of some of the key takeaways? What are the most important things for our listeners to remember?
I think one of the biggest takeaways is how dynamic and responsive the heart's blood supply is. It's always adjusting to meet the heart's needs, widening vessels when it needs more blood, narrowing them when it doesn't, and even creating detours around blockages.
It's like a living, breathing traffic control center, keeping everything moving.
Exactly. Another key takeaway is that even small disruptions can have big consequences. Stenosis, even if it's not causing problems at rest, can prevent the heart from keeping up when it needs to work harder, and that can lead to problems during exercise.
So we need to pay attention to those early warning signs, like chest pain during exercise, and not ignore them.
Absolutely. Early detection and treatment can prevent bigger problems later on. And speaking of prevention, another important takeaway is the importance of lifestyle choices for heart health.
Right. We haven't talked a lot about prevention today, but it's crucial. What are some of the key things people can do to protect their hearts?
Well, a lot of the risk factors for heart disease, like high cholesterol, high blood pressure, diabetes, smoking, all that, are things we can change. We can take steps to lower our risk. A healthy diet, regular exercise, maintaining a healthy weight, not smoking, all that can significantly reduce the risk of developing heart disease.
It's like taking good care of your car. Regular maintenance and checkups can prevent breakdowns.
Exactly. And just like with a car, early intervention is key. If you notice any warning signs, don't ignore them. See a doctor right away to get the help you need.
This has been a really informative deep dive into how the heart works. We've learned about the network of blood vessels, the balance of supply and demand, what happens when there are blockages, and how adaptable and resilient the heart is.
It's been great exploring this topic with you.
And to our listeners, we hope you've learned something new about your own heart and are inspired to take good care of it. Until next time, take care of yourselves and those amazing hearts of yours.
Yeah, it's been really fascinating looking at all these details of the heart.
It has. From those big coronary arteries to the tiny capillaries, and seeing how the whole system adapts to problems. It makes you realize how hard your heart is working all the time.
It does. And it really emphasizes how important it is to, take care of our hearts, make healthy choices. We talked about diet, exercise, managing stress. But even something as simple as getting enough sleep, that can have a huge effect on heart health.
It's like we've got a roadmap now for keeping our own hearts healthy.
Exactly. We know what makes the heart vulnerable, and we've seen how tough it can be. Now it's up to each of us to use that knowledge, make good choices for our hearts, and to pay attention to any warning signs. Get medical help if something feels off.
We owe it to our hearts to take care of them. Before we go, I want to thank the London Heartbeats Academy again for all their help. They've given us so much info for this deep dive, and I want to encourage our listeners to visit their website, check out their social media. They've got great courses, and they're always adding new stuff, keeping up with the latest in heart care.
Yeah, they're a great resource for anyone who wants to learn more about the heart, whether you're a doctor or just curious about how it works.
And to our listeners, we hope this has inspired you to learn more about your own heart and make choices to keep it healthy and strong. Until next time, take care of yourselves and those amazing hearts of yours.